Thank you, everybody, for joining us today for Cholera Prevention 101. Before we get into the specifics of cholera and the definition of it, first we're going to talk about the professional planning of each of our roles in this group. So first, I will be taking the role as an infectious diseases physician, and in this, I will be talking about the tasks of a physician, and this includes the education, the awareness, and treatment prevention plans. This also will include like what happens, such as the symptoms and signs, and some treatment plans that will be given for patients, as well as prevention plans for furthering care, such as vaccinations for both US and global. So a couple of the tasks and the goals that will be in place for a physician is to do education. So to describe what is cholera to patients, as well as awareness. So explaining symptoms, risks, bodily harms that can actually happen from cholera. Goal 3 is treatment, such as vaccinations, medications, etc. And goal 4 would be prevention, which is preventative measures and how to stop the spread. So first is what happens. What are some signs, some symptoms, and treatments that you can take along with these symptoms? First is dehydration, which is extreme thirst. You'll have rapid pulse, sunken in eyes, and a popular treatment plan for this is rehydration therapy. And this is done by using an ORS, an oral rehydration solution. This is crystals that you put into sanitized water and you drink a lot of it to keep you hydrated. Another sign is diarrhea, and you'll have abdominal bloating and urgency. So this you'll also use an ORS. And then you'll have symptoms such as nausea or vomiting, and you'll have lack of appetite or diaphoresis, which is extreme sweating. And then you'll normally have anti-nausea medication such as Zofran. So next is prevention planning. So cholera vaccinations are really important. And in the US, you will have Vaxchora only available to you. And this is recommended for 2 to 64-year-olds, and it's effective for 3 to 6 months. It's one dose that you take typically 10 days prior to traveling. Next is Dukoral, which is available in many countries, but just not US. And it's recommended for 2+ year olds. And then this is actually 2 doses. So it's going to be 1 to 6 weeks in between doses to make sure it has the best capabilities of prevention.
Hello, everyone. My name is Brian, and I'm the evolutionary biology researcher. And my goal is to study the treatment of cholera from an evolutionary perspective. And through this, I am studying the trends of cholera over time in different regions, as well as devising a plan to minimize the development of resistance regardless of geographic location. And lastly, my goal is to manage cholera and the different genetic variations to ensure that it does not become more difficult to treat and more contagious. Cholera actually originated in the Ganges Delta River, which is near the Indian subcontinent. The first pandemic was in 1817, which then spread from India to Asia, Europe, and the Americas, and then to Africa. So this was the first version of cholera before it began to mutate. Vibrio cholerae is the most common bacterium associated with cholera, and this one has been thoroughly studied, and we have made significant strides in its treatment and continue to make strides for this specific bacterium. Our cholera resistance plan, or treatment resistance plans, is derived in a multifaceted version to prevent the development of antibiotic resistance through both antibiotics and vaccines. 2 common antibiotics are tetracycline and doxycycline, which are most effective. However, over time, resistance has developed due to both overuse and continual use in different geographical locations. Azithromycin is the World Health Organization's newest recommendation because it's less likely to be derived from resistance. As you can see from the chemical structures, 2 of them, tetracycline and doxycycline, are both very similar, whereas azithromycin is slightly different. And our treatment plan is to have a combination of these different antibiotics to ensure that it's harder to obtain resistance. Some previous literature that our team assessed showed that having a mixture of these antibiotics makes it more difficult for cholera to develop mutations to these treatments. The next goal of this plan is to have contact tracing within local communities. because as we can see from the evolutionary history of many diseases, contact tracing is a vital way to prevent the continual transmissions, which eventually leads to stronger mutations. Vaccines are another great way to treat cholera, and the combination of vaccines and antibiotics has been shown to reduce resistance and be more effective in treatment versus just vaccines or antibiotics. Lastly, my goal as an evolutionary biology researcher is to track the genetic strains and genetic variations. And this is through whole genome sequencing, which is the best way to differentiate between different cholera strands. Our previous research has shown that there is a geographical difference between cholera strains depending on the location. And we are working with local officials and local guidelines to ensure that we're able to track the development of resistance in these regions. And lastly, preventing new and more infectious strains is our priority to prevent future outbreaks.
Hello, everyone. My name is also Brian, and I was tasked with the local community health advocate. Now, part of my, role is increasing the public awareness of cholera as well as promoting healthy practices. With this, it's going to also strengthen the community engagement and also develop an emergency response plan. Part of that plan is going to be, our comprehensive cholera awareness campaign, right? So exactly how we're going to do this is we're going to have to educate the public about cholera, right? Include symptoms, preventions, treatments. Exactly how we're going to do is going to be variable, right? So we're going to have pamphlets. We can also do organized workshops. Another thing that we could implement is making sure that we collaborate with schools, healthcare centers, and also community leaders to make sure that we are effectively spreading the information. And also, part of coming into a local community is making sure that we are aware of the cultural sensitivity. So making it kind of like important that we have like access materials with various languages and formats. Another way that we can see the effectiveness of our campaign is going to be through our surveys and also our feedback sessions. Now, exactly how we're going to make this, we're going to try to implement a hand hygiene and safe food practices program, right? So how we do this, again, we're going to do the workshops. These are going to be educational workshops that can be done in schools, local markets, community centers. Really, the focus is to reducing cholera transmissions through this improved hygiene and food safety, right? So distribution of hand sanitizers, soaps, and other educational materials could help with that, as well as collaborating with local food vendors so they know what safe food preparations. We're going to do demonstrations in that way. And a way to check back with us with the community is making sure and monitoring the changes in the hygiene practices through periodic assessments and participation feedbacks. Now, for our next plan, which is going to be our monthly meetings, kind of like the meat of it, this is where we're going to get all our feedback. Is this working? So we're going to be doing like organized regular meetings with the community members to discuss cholera related issues. This is also going to be able to provide updates to the local health like initiatives that we're trying to do, and also gain feedback on any oncoming programs, right? So we're basically creating like a platform for community members to express concern, share experiences, as well as discuss like, health education, emergency preparedness, and even resource, distribution, right? So we also, this is a great setting to, evaluate the effectiveness by the people that are attending, the engagement, and also what else we can implement within these communities.
Hi, everyone. My name is Kate Alprin, and I'll be serving as the International Health Agency for our presentation. And specifically, I'll be focusing on the World Health Organization for our purposes. So as the International Health Agency, I have a couple of goals. The first thing is to provide a legal framework for the country's obligations in handling an epidemic. And that specifically is called the International Health Regulations. It just gives us a way to enforce that the countries are actually following and preventing the spread of the disease. The next one is to serve as the communicating body between member states and mediate any discussions that they're having about the best way to handle different scenarios or problems that might come up. Next is conduct global assessment of health events. So survey and see where the hot spots are, what places may be at risk. And then lastly, offer assistance and aid to member states in need, and gather support from members. So we have a huge fund of supplies, as well as personnel that we can use to assist our membering countries. So we'll provide them with help as needed. So what is the International Health Regulations? So the IHR is a legal framework that requires all World Health Organization members to detect public events in a timely fashion, report any public health events to the national IHR focal point. So there's a focal person within each country where if they have a public health crisis, they report it to them. And then it also requires them to respond to all public health risks and emergencies. So the goal is just to limit the spread of public health risks and hold all member states accountable for their own countries. Something that I found really interesting is in the past 9 years, 100% of the member states have reported an international health event. That's partially due to COVID, but there's just a lot of health events that everyone reports on. So this is a commonly used system. So the Global Task Force on Cholera Control, also known as the GTFCC. So this is a partnership of more than 50 institutions. So that includes NGOs, academic institutions, UN agencies, and the World Health Organizations. And it offers countries the capacity, tools, and assistance to develop their own national cholera plans. So the GTFC helps countries develop their own way of handling problems with cholera as they occur specific to their country, and versus just having one standardized plan for everybody. So it was created in 1992 in the context of the cholera outbreak in Peru. So just for some context on that, in Peru in 1991, they had a huge cholera outbreak where there was over 300,000 cases and over almost 3,000 deaths. So it occurred when a Chinese national brought a foreign strain of cholera to Peru called the El Tor strain. And for even some more context on this, the reason that it became so bad in Peru is that many cities had discontinued chlorinating the water supplies after there was a study that came out showing that chlorine can cause cancer. So it made them extra vulnerable and spread the disease through the country very rapidly. So following this event, that's when the Global Task Force on Cholera Control was created. And so what they do, the World Health Organization enforces the policies that the Global Task Force on Cholera Control develops. So GTFC is based on national plans, and then the differentiation is the WHO Cholera Plan is based on the whole global response. So Ending Cholera, a roadmap to 2030. This was an initiative that began in October 2017 in a partnership of the World Health Organization and the GTFCC. So the goal of the Ending Cholera roadmap to 2030 is to reduce cholera deaths by 90% and to eliminate cholera in as many as 20 countries by 2030. So one of the main ways that they do this is by stockpiling treatments so that they're available when needed. And this also helps reduce the cost for countries who have novel outbreaks. There's 3 strategic axes that this roadmap focuses on. The first one is early detection and a quick response to outbreaks. The second one is focus on cholera hotspots by giving them the oral cholera vaccine, as well as focusing on water, sanitation, hygiene, education in those countries. And then the third axis is to use the GTFCC for coordination of technical support, advocacy, and resources.
Hi, everyone. My name is Bhavik Rajabuena, and I'm serving as the lead anthropologist for this group. I have 3 main objectives I'd like to accomplish. The first is examining current trends have historically led to disease progression. In this particular case, I'm trying to understand what could lead to the formation of cholera, what trends lead to the formation of cholera. Second is to understand cultural and sociological practices across the world that could contribute to disease spread. And finally, the key component of my work, which is to conduct ethnographic field work with local families and individuals who are willing to participate so I can get a more hands-on view of what factors could lead to cholera spread. Let's examine some of the current trends that have historically led to the formation of cholera. The Center for Disease Control has explained that cholera is most likely to occur and spread in places that have inadequate water treatment and sanitation measures. And this fact can be quite literally verified by these two graphs at the bottom, because if you compare the graphs that highlight areas with the highest issues with sanitation and compared to the world map where there's high cholera rates, it's essentially that there's as if there was a copy and paste between these two graphs. Hence, the CDC's claim is quite verified. The reason this is important to consider is because contaminated food and contaminated water will often lead to the formation of cholera being spread around between individuals and populations. And because there's a lack of proper sanitation and lack of water treatment, this is only going to lead to more and more contaminated food and water sources, which leads to more and more individuals of cholera and unfortunately spread the disease. The second thing I'd like to consider as the anthropologist is specifically what cultural and sociological practices, in other words, what human behaviors can lead to the spread of cholera. And I found three main commonalities between the cholera hotspots across the world. First is open defecation practices. Oftentimes, many ethnic groups and culture groups have explained that they perform open defecation in order to fertilize their soil for farming purposes, but sometimes other groups may engage in open defecation mainly because they lack proper restroom infrastructure. And as a result, these fecal matter can find their ways into our water sources as well as food sources, leading to Vibrio cholera becoming more and more prominent. The second is also due to the plurality of languages making communication difficult. Despite how positive and how much eager people are willing to come to these countries that are suffering of cholera and spread information about cholera, the main issue is that there's a significant language barrier. And as a result, individuals of these countries may not be familiar with the English language, making it extremely difficult to pick up the knowledge from the aid groups, and therefore it will essentially result in it will not result in any progress being made with regards to providing education treatments to individuals with cholera. And lastly, arguably the biggest factor that's common between these groups is mistrust in Western medicine and the hospital structures. Many of these groups in foreign countries have explained that they do not have a significant trust in medicines made by the Western countries, and they'd rather have more faith in their traditional medicines. And lastly, they have had a lot of bad experiences with the local hospitals in the area, which is why they might not be open to rehydration therapies and receiving antibiotics, etc. The last thing I'd like to perform are ethnographic studies. Ethnographic studies, for those who do not know, are considered observational research studies that involve immersing oneself in the day-to-day activities of a research participant, but making sure not to interfere with those said day-to-day activities. The reason this could be extremely relevant to our group is because it provides three key forms of data. The first is information about specific cultural practices. For example, individuals who might engage in group eating practices may be more prone to spread cholera, or some individuals might perform burial practices that could result in the resurfacing of cholera in specific areas. Hence, identifying these specific cultural practices in a particular location may be useful for anthropologists and other research groups. The second would be to monitor and understand participants' views and knowledge of cholera. The reason this is useful is because we can understand how well versed the individuals are in the knowledge about cholera and whether they think it's a significant issue at all in the first place. This could be useful for local community health advocates to therefore identify what areas require more knowledge about the issues. And lastly, ethnographic studies can also provide researchers with a better understanding of how socioeconomic impact can make it more difficult to live and therefore increase the risk of developing cholera, mainly because lower socioeconomic groups have lower access to infrastructure, lower access to resources, and therefore understanding this firsthand might make it easier for researchers to communicate this data on a higher level.
I'll start there. Okay, cool. Okay, so we're going to go ahead and talk about the profile of cholera. So exactly what is cholera? Cholera is going to be the disease that is caused by the Vibrio cholerae bacteria, right? So we know this is going to be causing intestinal infections. We know that the disease is spreading through the contamination of water or food. So part of the symptoms that we're going to be seeing is going to be vomiting, reduced urination, increased thirst or intense thirst, severe diarrhea, and dehydration. So there's usually like an incubation period of 2 hours to like 5 days. So that's usually some of like the symptoms that you would like that you would notice initially.
So what are some risk factors? So one of them can be undeveloped areas such as urban living. Next is poor conditions or personal hygiene. Next is food hygiene and unsafe water and poor sanitation. So the contamination process starts solely by the bacteria. The bacteria can either go into water or into food. And with both of these, they can get either ingested and then into the intestinal system, or it can be cross-contaminated into one or the other, and then also be ingested or into a person's system. So a little graphic that we made for how to prevent cholera contamination. First would be to drink sanitized bottled water. Next is to clean and peel the fruit so then anything on the outside can actually get cleaned off. Next would be to remove garbage and to sanitize water. Next is do not eat raw food. You always want to cook everything thoroughly. Wash your hands and make sure that restrooms are very clean. Do not eat any fly-swarmed food. Anything that can defecate near food, you do not want to consume that as well. And then lastly, you want to get vaccinated as fast as possible and in between the proper time frames provided.
So next I'm going to go into a profile of Afghanistan, which is the country that we chose to focus on for our plan, as well as kind of why we chose to focus on Afghanistan. So Afghanistan has a current cholera outbreak. So the total population of the country is 42.2 million people. And right now, since the start of the year, they have 36,504 cases of cholera. So there's 5 countries right now that are like leading the charts for the number of cholera cases. The first one being Afghanistan, which is why we chose to focus on them, but the other countries are Cameroon, Democratic Republic of Congo, Haiti, Ethiopia. So those are all countries in dire need, but we chose to go with Afghanistan since they were number 1. Afghanistan country profile. So Afghanistan is primarily rural. So 71% of the population is living in rural areas, 24% urban, and then 5% are nomadic Kuchis. And there's a large population that's internally displaced. So as of 2022, 6.6 million people were currently living in internal displacement in Afghanistan. 2/3 of that was due to conflict and violence, maybe their homes getting destroyed due to violence, having to escape, things of that nature. And then the other 1/3 is due to natural disasters. And then also kind of coming off of that internal displacement, there's a lot of people who are unvaccinated since they're not followed by a primary care practitioner and have had to move throughout for the past couple of years. And then another consideration that we took in when making our plan was that due to the Taliban, women are especially vulnerable for medical issues. The big reason is they're unable to get work or get an education. So initially when the Taliban took charge in Afghanistan, they were discouraging women from working altogether. But in 2021, they came and said if women were working in healthcare, they could return to work. But a lot of the population has still been hesitant to return. But the reason that this is a problem is Afghan cultures for women not to seek health services from a male practitioner. So there's currently not enough female practitioners for women to go see. So even if they're able to go leave the house and get healthcare, they may not be in a situation where they feel comfortable receiving it. And then another consideration that women have when receiving healthcare is due to the Taliban, they cannot travel more than 45 miles without a male to escort them. And there's another mandate saying that their male escort needs to be present during the whole visit. So this limits where they can seek practitioners, as well as their willingness to talk about health issues that they may be having. Afghanistan healthcare access. So in 2018, just over 3,000 health facilities were functional, so about 87% of the population had access to healthcare. However, the healthcare system is still severely underfunded. In 2004, the Afghanistan Constitution was revised, saying that they would provide free healthcare to all the citizens, but they didn't have enough money to do that, so 75% is still funded by households. And because of this, they're currently receiving a lot of humanitarian aid. It's kind of what is keeping the healthcare system going. So this year, the World Health Organization has 4 million people targeted to receive aid in Afghanistan, but still 8 million people don't have access to any healthcare, or don't have access to healthcare, and that includes 450,000 people who don't have access to trauma care. So if they were to have a medical emergency happen, they wouldn't have anywhere to go. And there's 28.8 million people in Afghanistan who require immediate assistance. And so because of this, in August, the World Health Organization announced that they need an additional $125 million in funding to continue to sustain the basic healthcare needs for the remainder of this year in Afghanistan. This is partially due to the current cholera outbreak, as well as the increase in violence that the World Health Organization wasn't prepared to fund.
Let's transition into a discussion about the current profile of current treatments. The treatment protocol for individuals with cholera consists of 3 key components, the first being antibiotics, which includes doxycycline, azithromycin, as Brian talked about, and sometimes ciprofloxacin. The reason for this is because cholera is caused by the bacteria Vibrio cholera, and hence antibiotics might serve as a first form of treatment and a first-line defense against the spreading of the toxins from this bacteria. The second 2 other forms are IV hydration and zinc supplementation. The reason for these 2 forms of treatment is because cholera toxins can lead to significant water loss and hence symptoms of diarrhea, dehydration, which can therefore also lead to shock and fainting. This is why IV hydration and zinc supplementation have been identified to combat and rehydrate individuals to prevent these symptoms and prevent death. Current costs of treatment for doxycycline include $13 for 200 milligram tablets, which is the antibiotic. The second other form of treatment, which is the zinc treatment, is about $15 per patient. And the average cost of IV hydration is around $14.28. This particular statistic was referring to children, but nonetheless, this number gives an idea of what IV hydration can cost for an individual. Then while these numbers might seem a bit average or normal for the average American, if you compare these numbers to the average Afghan income per capita of $520, one can recognize that in a yearly salary, it's going to be extremely difficult to cover these expenses. And this is where we require a lot of financial need. The first is to rehabilitate, potentially, Afghanistan's pharmaceutical sector. The BMC explains that Afghanistan's pharmaceutical sector is considered one of the least developed globally. So not only are the medicines they have, they're quite expensive due to lack of ability to produce drugs, but secondly, the quality of drugs might not be as good as well. And that's why funding and financial support could be used for either A, purchasing drugs from abroad, such as purchasing antibiotics and vaccines from abroad to provide to the individuals with cholera, or B, the money could be used to rehabilitate Afghanistan's pharmaceutical industry, partially in order to continue the building up of drugs to save individuals' lives. And lastly, the additional funding could be used for the educational programs that Brian talked about earlier, as well as contact tracing programs in the performance of limiting the spread of cholera.
Our team strongly believes that our plan is very effective at both preventing cholera and treating it. Through preventing cholera, our team plans to have lots of different community outreach. This will look like grassroots, where people will be going door to door to talk to people in the community, as well as hosting stands or information sessions and workshops in public areas. Next, we plan to educate the public on safe practices to prevent cholera and prevent the spread, because this is ultimately what will lead to the lack of need for future treatment that could lead to resistance and death. The next point that our focal point of our plan is early detection, because once we find people who have cholera, we want to include lots of contact tracing and lots of education to the public to prevent that cholera from spreading. Next, our team wants to prevent the development of resistance to treatment, and this will be done through smart use of antibiotics, because traditionally, some people want to take as many antibiotics as they can when they have a disease like cholera to hope that it goes away. However, our team wants to minimize dosages and study what the most effective is to both treat the disease and prevent resistance. That we will be doing this through monitoring the symptoms and seeing what is improving and what is not. And lastly, we want to work with local healthcare professionals to empower them to be best at treating cholera, because communities ultimately need long-term support and long-term plans. And our team wants to work with these communities to ensure that there is a plan in place for the long term and ultimately to prevent the development of other diseases as well. Next, we obtained some questions from our peers, and we would like to answer them in order to best strengthen our approach. The first question we received is, how will you ensure that your roles work together cooperatively to create a balanced and nuanced plan? So it is true that we do have different roles within one plan, but this is actually a strength because our team wants to drive a holistic plan to prevent the spread of cholera through different mechanisms. For example, the physician and evolutionary biology researcher will be more motivated to look at the historical progression and gene sequences of cholera, whereas the international agency and local community advocate will work on deploying what the different treatment options and preventative education plans that we derive. And I think this holistic interdisciplinary approach is actually what makes our plan very effective, because we have experts in different fields that will work together to ensure that we can most effectively combat cholera.
All right, and another question that we were asked is what method would be used to share this information with the community? And like we said previously before, so our team is trying to use various different ways on how to share this valuable information with communities. One being presentations and workshops, having these demonstrations on how to practice hand hygiene, food safety practices and stuff like that. This could be taking place in either schools, parks, malls. Another way is also recruiting volunteers to go door to door with informational pamphlets and brochures, making sure that the community can read the information and understand it. As well as one of our last steps is not only involving the community, but also furthering it with media. So this could be like going to any local radio stations, if there is commercials to further share the findings and within the community, because this not only is going to allow our team to spread the message, but then this would also get peers to be talking about cholera and how it affects them, personally.
So the next question that we were asked is, where will this information be posted? So since there's multiple avenues to disperse this information, such as presentations, going door to door, or utilizing the media, we also plan to create a website. This will ensure the community has a place to get the correct information and that all of their facts are up to date. On this website, we plan to post resources that we want to spread through the community, so they could go back and refer to it whenever they need. And then additionally, this will be a great place to post up-to-date case numbers.
Thank you all very much for taking the time to listen to our presentation, and we hope that you will continue to support our group's efforts to combat cholera and improve the quality of life for cholera patients. Thank you.